Imagine your thoughts as prisoners you cannot set free. Obsessive thoughts about compulsive cleaning that torment you constantly. Deep fear of contaminating beloved people. Doubts that literally never end. Compulsions that steal hours from your day while you try desperately to maintain sanity. Welcome to obsessive-compulsive disorder, one of the most misunderstood and devastating psychiatric disorders affecting between 2 to 3% of the world population right now. OCD is not just a little anxiety or normal worry that everyone occasionally experiences. It is absolutely not simply an organized or perfectionist person, as people ignorantly and romantically claim. It is a profound neurobiological disorder where the brain literally becomes trapped in pathological thought patterns that continuously reinforce themselves through destroyed neural mechanisms. Between 250,000 and 600,000 Brazilians suffer with OCD right now as you watch this video. Some spent hours washing their hands until they bleed profusely. Others compulsively check if they lock the door hundreds of times per hour. Many fight daily against terrifying obsessive thoughts about harming people they love deeply, thoughts that torment them relentlessly day and night without rest. This video reveals the deep neurobiological secrets of OCD, from completely destroyed brain circuits to the compulsions that literally define and consume the entire lives of those afflicted. Prepare yourself to truly understand what it is like to live imprisoned inside your own OCD-affected mind. OCD, scientifically termed obsessive-compulsive disorder, is a severe and complex psychiatric condition characterized by two main components working together destructively: obsessions and compulsions that feed each other. Obsessions are recurrent, persistently intrusive, and deeply unpleasant mental thoughts, urges, or mental images that invade consciousness against the person's expressed will. Unlike normal thoughts and everyday worries that we all occasionally have, obsessions in OCD are ego-dystonic, meaning exactly that the affected person completely recognizes them as completely irrational and without any logical sense, yet is absolutely incapable of controlling or eliminating them from their minds. These obsessive thoughts cause intense anxiety or significant psychological distress that interferes significantly with daily activities, professional functioning, and personal relationships with family and friends. Compulsions, on the other hand, are repetitive behaviors or mental acts that the person feels psychologically compelled and obligated to perform in direct response to obsessions, often following rigid rules established by the disease-affected mind. Some patients present pure obsessions without apparent compulsions, but most experience both simultaneously in an intermingled and continuous fashion. One of the most disturbing facts revealed by rigorous epidemiological research is that 55% of cases in the general community present only obsessions without apparent compulsions, while 70% of patients seeking professional clinical treatment present obsessions and associated compulsions. This clearly suggests that many millions suffer silently without ever seeking professional help due to shame or fear. The population prevalence is significantly greater than historically believed for decades by naive professionals. While older studies considered OCD a rare and obscure disease, rigorous modern controlled international research estimates that between 1.0 and 2.5% of the world population suffers from OCD throughout their entire lives. In specialized psychiatric clinics, this number jumps dramatically to approximately 10%, making OCD the fourth most common psychiatric diagnosis after specific phobias, substance-related disorders, and major depression. The disease affects both men and women equally, although women are statistically slightly more diagnosed, possibly due to persistent male underreporting and increased shame. Unlike other severe psychiatric conditions such as schizophrenia or bipolar disorder, OCD frequently maintains preserved insight in most clinical cases. Patients clearly and completely recognize the profound irrationality of their destructive thoughts and compulsive behaviors, which paradoxically increases exponentially their overall psychological suffering. The continuous struggle against their own irrational thoughts and uncontrollable impulses is exhausting at a profound neurobiological level, frequently leading to severe chronic mental fatigue, significant comorbid depression, and generalized anxiety in approximately 62% of clinically diagnosed cases. This comorbidity frequently dramatically complicates the overall clinical picture and significantly reduces the overall quality of life for those afflicted. Here lies the neurobiological truth that is truly terrifying and revelatory for understanding. Revolutionary and sophisticated neuroimaging studies revealed that the brain of people with OCD functions in a fundamentally different and abnormal way compared directly to neurologically healthy brains. Specifically, there is abnormal and pathological hyperactivity in the corticostriatal thalamic cortical circuit, CSTC, a complex neural network that should coordinate voluntary movement, emotional motivation, and critical filtering of potentially irrelevant or dangerous thoughts. This circuit consists of three anatomically connected main brain structures: the orbitofrontal cortex that evaluates potential threats, the striatum or caudate nucleus that processes reward and habit formation, and the thalamus that filters sensory and cognitive information. In neurologically healthy individuals, this circuit functions as a sophisticated system of efficient detection and filtering of unnecessary false threats. The brain perceives a potential threat or danger, evaluates it rationally, considering all relevant contextual factors, and if determined that it is not actually a genuine and present threat, the thalamus proactively blocks that information so that it does not reach consciousness. In people with OCD, this neuroprotection mechanism fails catastrophically and completely in its functions. Specific neurons of the orbitofrontal cortex fire repeatedly and abnormally, continuously signaling danger and threat that absolutely does not exist in objective reality. The striatum, instead of processing this distorted information normally, amplifies and intensifies even further the false threat signal. The thalamus simultaneously fails to filter effectively, allowing distorted and pathological information to reach consciousness. The neurobiological result is an infinite and relentless neural loop that perpetuates itself: repeated false alert, amplified fear response, compulsive behavioral response for relief, maladaptive reinforcement of the pathological pattern. Recent studies with high-resolution functional magnetic resonance imaging, fMRI, showed that approximately 250 genes were identified as significant genetic contributors to OCD development in vulnerable populations. These genes are most active in three brain regions critical to the disease: the hippocampus, responsible for memory and context, the striatum, that governs automatic habit formation, and the cerebral cortex, that performs superior cognitive processing. This absolutely important revolutionary discovery, published in Nature Genetics in 2024, involved complex statistical analysis of more than 50,000 people diagnosed with OCD versus 2 million healthy controls, representing the largest genetic study of OCD ever conducted in international scientific history. Neurotransmitters also play an absolutely central role in this complex neurobiological pathology. Serotonin is the most widely studied neurotransmitter in contemporary OCD research. The classical serotonin hypothesis suggests that significant dysfunction in serotonin transmission between neurons fundamentally contributes to observed obsessive-compulsive symptoms. Patients with OCD show clear and consistent serotonin dysregulation that prevents normal and adaptive regulation of fear, anxiety, and rational decision-making. Dopamine is also clinically relevant, particularly in mesolimbic reward brain pathways. Compulsive behaviors abnormally activate dopaminergic pathways, creating paradoxical reinforcement that perpetuates the destructive compulsive cycle. Glutamate, a potent excitatory neurotransmitter, contributes to abnormal synaptic plasticity, allowing dysfunctional neural circuits to strengthen through continuous repetition of the pathological pattern. OCD is not limited simply to repeatedly washing hands or checking locks multiple times, although these are common manifestations and most publicly known. Specialized researchers have identified approximately 18 different and distinct OCD subtypes, each with their own unique and specific obsessive and compulsive patterns. The 5 main thematic groupings were identified through rigorous statistical analysis of approximately 300 documented clinical cases, and these 5 main types explain more than 60% of the clinically observed symptomatological variation.
The first main type is checking OCD, where patients obsessively check if doors are properly locked, stoves turned completely off, or if they committed significant professional errors. The central obsessive fear is that something terrible and catastrophic will happen if they do not check repeatedly multiple times. A typical patient may check their car 50 times before managing to leave the parking lot, or spend an entire hour verifying they correctly sent a crucial work email. This checking compulsion causes the characteristic pathological doubt, the terrible and unbearable feeling that there is never enough certainty no matter how many times you check repeatedly. Contamination OCD is one of the most debilitating and disturbing subtypes of all clinically. Patients obsessively fear contamination by invisible germs, blood, dirt, or dangerous chemical toxins. Even more disturbing is the expanded concept of mental or moral contamination, where patients fear that morally immoral people or traumatic events can psychologically contaminate their mind through mere association or thought. Compulsions can include washing hands hundreds of times daily until bleeding profusely, obsessively avoiding touching anything outside the house from extreme fear, or discarding entire clothes that touched people considered contaminated. Symmetry and ordering OCD involves obsessive need that material things be symmetric, ordered perfectly, or feel correct psychologically in an intuitive way. If something is misaligned or incomplete in any form, patients experience unbearable intense distress. Frequently affects children and adolescents more than adults. Compulsions can include organizing items for uninterrupted hours, compulsively counting objects repeatedly, or reorganizing until achieving the correct feeling of "it's right now." Intrusive thoughts and rumination involve purely mental obsessions about disturbing themes such as loss of control, immoral, religious, blasphemous thoughts, or concerns related to unwanted and repugnant sexuality. These are particularly disturbing because the compulsions are completely mental: circular mental repetition, cognitive neutralization of thoughts, obsessive seeking for reassurance. Patients can spend literally hours in circular mental discussions trying to solve an obsessive thought that is inherently logically unsolvable. Collecting or hoarding OCD involves irresistible compulsive need to compulsively collect or keep items that appear to have absolutely zero or negative value. The central fear is that throwing something away will cause something bad or be fundamentally morally wrong. Unlike simple accumulation, in OCD, there are specific active obsessions continuously driving the compulsive behavior. OCD not only causes intense and constant uninterrupted psychological suffering, it causes severe and progressive functional disability in multiple important life domains. Epidemiological studies show that 62% of OCD patients have comorbid diagnoses with other psychiatric disorders simultaneously present. The most common are major depression, 37% of cases, generalized anxiety disorder, 31%, panic or agoraphobia disorders, 22%, significant social phobia, 17%, and specific phobia, 15%. This complex overlap of multiple diagnoses makes treatment dramatically more difficult and complicated, significantly reducing the expected prognosis for recovery. The economic and productive cost is immense and frequently completely ignored by authorities. Patients with OCD have much higher rates of work absence for days or entire weeks, complete inability to maintain stable employment, and devastating relational conflicts. Marriages frequently deteriorate and end under the unbearable weight of compulsions. Relationships with children suffer significantly when compulsions consume literally all hours that could be dedicated to family and interpersonal relationships. The overall quality of life of OCD patients is frequently comparable to, or even worse than, that of patients with severe untreated depression or schizophrenia. Many patients face deep and irrational guilt about their terrifying, intrusive, obsessive thoughts. A patient with harm OCD, obsessive thoughts about harming, describes being trapped in a state of continuous and inescapable horror when contemplating disturbing thoughts about harming beloved people. Although these patients practically never act on these unwanted and violent thoughts, the psychological distance is absolutely zero. They live in constant terror of themselves, secretly believing they are fundamentally evil, despite rational logic saying completely the opposite. Unlike many chronic and intractable psychiatric conditions, there are clearly effective science-based treatments for OCD when correctly implemented by trained and experienced professionals. The internationally established gold standard therapeutic approach is the synergistic combination of cognitive behavioral therapy, specifically the technique of exposure and response prevention, combined with appropriate and well-monitored pharmacotherapy. Selective serotonin reuptake inhibitors, or SSRIs, are the first-line recommended medication according to international protocols. The most effective and extensively studied are fluoxetine, fluvoxamine, Paroxetine, Sertraline, and citalopram in elevated doses. Clomipramine, a tricyclic antidepressant with more potent serotonergic properties, is also clinically effective, but causes more significant side effects. Controlled studies show SSRIs reduce symptoms in approximately 40 to 60% of clinically diagnosed patients. Crucially, the doses required for OCD are 2 to 3 times higher than those used for depression, and the time needed for complete response is longer, frequently 8 to 12 weeks or even more. Cognitive behavioral therapy, particularly the exposure and response prevention approach, is equally clinically effective. In ERP, the patient is gradually exposed to stimuli that provoke obsessions while being prevented from performing behavioral relief compulsions. Initially increases anxiety, but the spontaneous anxiety reduction that occurs when the patient does not perform the relief compulsion. Important neural reconditioning. Multiple repetitions strengthen new healthy neural associations where obsession is not linked to irresistible compulsive need. The combination of SSRI plus CBT produces higher remission rates than either treatment alone. Approximately 50 to 60% of patients show significant response when both approaches are correctly employed. Approximately 30% of patients are treatment resistant. In these cases, alternative strategies such as deep brain stimulation, virtual reality therapy, or innovative medication combinations offer new possibilities. Obsessive-compulsive disorder remains one of the most debilitating and profoundly misunderstood conditions in contemporary modern psychiatry. It is not an interesting personality trait or sign of creative genius as it is sometimes romantically portrayed. It is a profound neurobiological disorder that deserves serious medical recognition and appropriate specialized treatment. If you or someone close to you experiences obsessions and compulsions consuming more than 1 hour daily, seek evaluation by a specialist trained in OCD. Recovery is possible, but first, silence must be broken. The next step is yours. Freedom from mental prison is possible.